Good evening, everyone. I'm Michelle Leifer, the director of the USDAN Institute for Animal Health Education at the Schwarzman Animal Medical Center. Along with my colleague, Valeria Menendez, I'd like to thank you for joining us for tonight's event, Thyroid Disease in Dogs and Cats from Hypo to Hyper, with Dr. Mariel Covo, specialist in internal medicine at AMC. This webinar is for informational and educational purposes only and is not intended to substitute for professional veterinary medical advice, diagnosis, or treatment. If you have questions or concerns about your pet's health, it's always best to consult your veterinarian. Tonight's event is being recorded and we'll send out a link tomorrow in case you miss anything or would like to share it with a friend. We'll be taking questions via the chat box and we'll save time at the end of the presentation to answer as many as possible. The chat box will be disabled until right after Dr. Covo finishes her PowerPoint presentation, and I will then turn it on and you can put your question in at that time. I'd like to take a quick moment just to let you know about next month's webinar, Dental Health in Dogs and Cats, Signs, Treatment, and At-Home Care with Dr. Brad Singalani, resident veterinarian in AMC's Dentistry and Oral Surgery Service. That event will be held on Thursday, February 26th at 6 p.m. You can register on our website at amcny.org/events, and that link will also be included in our newsletter going out tomorrow evening. And now it is my pleasure to introduce tonight's speaker. Dr. Mariel Covo grew up in New York City and earned her undergraduate degree from Yale University. She received her veterinary degree from the University of Pennsylvania School of Veterinary Medicine and completed a rotating internship and a 3-year residency in internal medicine right here at the Schwarzman Animal Medical Center. We were very fortunate that she stayed on and is now a senior veterinarian in AMC's internal medicine service. We're grateful to have her here with us this evening. Please join me in welcoming Dr. Mariel Covo.
Hi, everyone. Thank you, Michelle, for that introduction. I'm going to go ahead and share my screen. All right. Okay, so hopefully that is looking okay.
Good.
Okay, wonderful. So welcome, everyone. Thank you so much for taking the time out of your evening to learn a little bit more about thyroid diseases. We will be covering hypothyroidism and hyperthyroidism, so it is a big topic for 1 hour, but hopefully we will hit all of the important topics for you as pet owners to know. So we will get right into it. So we're going to start with a little bit of thyroid physiology so that we can understand how the thyroid works, how thyroid hormone is made, and the effects on the body. And then once we understand how it works in a normal setting, then we can better understand when there is too little or too much thyroid hormone, how that disease manifests. So we'll then get into hypothyroidism and then hyperthyroidism. And my goal is for you as pet owners to be able to identify clinical signs, understand treatment, and understand how we monitor this disease. So getting right into thyroid physiology, we're going to start with basic anatomy of the thyroid gland. It consists of 2 thyroid lobes on each side of the trachea, which is the windpipe. A little bit of a history lesson. It originates from the Greek word thyrios, which means shield, based off of the physical appearance of how it lays on the trachea, and it was first described in the 16th century. So as we start to zoom in on the thyroid and look at it at a more microscopic level, we identify the functional unit, which is the thyroid follicle, which you can see here. So the follicle is a sphere that is comprised of a line of epithelial cells, which are follicular cells, and there is a substance called colloid in the center. Colloid is a gel-like substance that contains thyroglobulin, which is a large glycoprotein that is a precursor to thyroid hormone. So It essentially acts as a reservoir for thyroid hormone to be able to be made by the follicular cells. And then I just want to note we do have these little parafollicular cells that are in between the thyroid follicles, but they are more so involved in calcium regulation and not thyroid regulation. So we're not going to talk about them too much. I just wanted to point them out. So the actual production of thyroid hormone is very complicated. It's a multi-step process that I certainly would not expect pet owners to fully know. But I do want to highlight some of the important parts in the details because those details become relevant when we talk about diagnosing thyroid diseases and how we treat thyroid diseases. So we have our thyroid gland here and we zoom in to our thyroid follicle. And now here we are looking at just one single follicular cell. The follicular cell is what is going to generate thyroid hormone. So it starts with trapping iodine. So iodine is in the bloodstream and it takes iodine and takes it into the cell and all the way across the cell into the colloid, where it is then made into iodine. Iodine is an essential part of thyroid hormone production. At the same time, the follicular cell makes thyroglobulin, which is that precursor to thyroid hormone, and it is then stored in the colloid. This thyroid cell will then receive stimulation to create thyroid hormones, which are called T3 and T4, and it takes the iodine and puts it on the thyroglobulin and then uses that to make thyroid hormone. And that thyroid hormone is then transported back across the cell into the capillary, where it is then released into circulation. So that is the general process of how thyroid hormone is made. It is important, though, to sort of take a step back and understand how is this process being regulated? Who is telling the thyroid gland to make thyroid hormone and how does it stop making thyroid hormone? So that is where this axis of regulation comes in, and it is called the hypothalamic pituitary thyroid axis. So this is basically one big feedback mechanism that fine-tunes thyroid production. It starts in the brain with our hypothalamus, and the hypothalamus creates a hormone called thyroid releasing hormone, which then goes and acts on the pituitary gland. It tells the pituitary gland to create thyroid stimulating hormone, which then goes into circulation and acts on our thyroid cells. The thyroid cells, then in response to thyroid stimulating hormone, will make T4 and T3, which are the thyroid hormones, and then those go into circulation and act on tissues, which we'll talk about. But one of the other things that they'll do is they'll go back up to the brain and provide negative feedback to the hypothalamus and to the pituitary gland. So it tells the hypothalamus to stop releasing TRH and tells the pituitary gland to stop releasing TSH. So it sort of puts the brakes on this cycle. And so this whole cycle is sort of a cyst of checks and balances, and it allows the body to fine-tune the control and how much thyroid is being released. Just touching on the main players here, so our thyroid hormones, we have two main thyroid hormones, so thyroxine, which is T4, and triiodothyronine, which is T3. Those just differ by how many iodines there are attached. So T4 has 4 and T3 has 3. T4 is made in greater quantities by the thyroid gland, but most of it is converted to T3 in peripheral tissue. T3 is actually more biologically active than T4. And T3 and T4 are both highly protein bound. So when they are in the bloodstream, the vast majority of them are attached to proteins, and only a small percentage, about less than 1%, is free from proteins. And that is the proportion that is biologically active and can act on our tissues. So as thyroid hormones start to act on tissues throughout the body, they can have many, many different effects. So they are essential for growth and development. They increase metabolic rate of most body tissues in a catabolic manner, meaning they take larger molecules and break them down into smaller units, and in that process, release energy that can be used by cells for storage or function. They regulate mental awareness. They increase blood pressure and glomerular filtration rate, which is an estimation of renal function and blood flow to the kidney. They increase heart rate and the strength of contraction, increase fertility, and are important for the fetal development. And they also will stimulate red blood cell production, protein synthesis, and carbohydrate metabolism. So as you can see, thyroid hormones really have their hands in all of the different body systems. And so you can imagine when there's too little of it or too much of it, we can see disease manifest in many different ways in the body. So diving into hypothyroidism now. The majority of the hypothyroid section will be focused on dogs, and in the end, we'll touch on cats a little bit. So hypothyroidism is defined as a decrease in thyroid hormone production. It is the most commonly diagnosed endocrine disorder in dogs, though there's a little bit of debate as to whether it is actually the most common because it can be very easy to overdiagnose, and we'll talk about why a little bit later. Its prevalence is about 0.2 to 0.8%, but in certain predisposed breeds, we can definitely see it more common and a higher prevalence. So how do dogs get hypothyroidism? By far, the most common etiology is what we call acquired primary hypothyroidism. So acquired meaning that it happens, it develops after birth. Primary meaning that the problem is coming from the thyroid gland. So in this whole axis, the problem is with the thyroid gland itself, either a defect or dysfunction that occurs where they're not producing thyroid hormone. Some rarer causes include congenital hypothyroidism, congenital meaning that the animal is born with it, and central hypothyroidism. So central hypothyroidism is when the problem is at the level of the brain. So it can be secondary hypothyroidism, which is when the pituitary gland does not function correctly and we don't release TSH, or tertiary hypothyroidism, where the problem is with the hypothalamus and we don't release TRH. Tertiary hypothyroidism is very, very rare, but I did just want to mention it. So, as I said, acquired primary hypothyroidism is going to be the most common cause, and different diseases can lead to that. The two most common diseases are going to be lymphocytic thyroiditis and thyroid atrophy. It's about a 50-50 split between the two. So lymphocytic thyroiditis is an autoimmune destruction of the thyroid gland where our normal thyroid tissue basically gets replaced by or infiltrated with inflammatory cells, and over time that can lead to fibrous tissue and scar tissue replacing that normal tissue, and then the thyroid cells cannot function normally and generate and secrete thyroid hormone. Thyroid atrophy is more a degenerative process. So that occurs when the normal thyroid gland is replaced by fatty tissue and can no longer function because of that. There's a little bit of debate and potentially some evidence that thyroid atrophy might represent an end stage of lymphocytic thyroiditis, but that has not been completely ironed out and is not thought to be the case sort of in every scenario. We have these two histology images here. So these are biopsies of the thyroid gland that show these two different disease processes. So on the top, we have lymphocytic thyroiditis. So we can see the thyroid follicle here with colloid in the center, that light pink, and it's surrounded by all of these little purple dots, which are inflammatory cells. So we can see there are a lot of cells in between these follicles, and that represents that autoimmune inflammation. Contrasting that to thyroid atrophy, we can see these thyroid follicles here with our colloid, and there's a lot of just what looks like empty space in between them. that's actually where the fat is depositing. And we can see we don't see a lot of inflammatory cells. It is more just this empty space with fat in between these cells. Some less common causes of acquired primary hypothyroidism would be from radiation therapy, certain drugs like Palladia or TMS, which is an antibiotic, and then thyroid cancer very rarely, but can cause hypothyroidism. So who gets hypothyroidism? There are many different breed predispositions, some of which include golden retrievers, English setters, giant schnauzers, boxers, Doberman pinschers, a lot of big dogs in the textbooks, but we certainly see it in little dogs as well. They tend to be middle-aged to older, and there is some conflicting data, but potentially females might be at slightly greater risk. So hypothyroidism causes a variety of clinical signs, and these clinical signs often are subtle and have a pretty gradual onset. You're not going to wake up one day to the next and say, I think my dog has hypothyroidism. It's going to be a more sort of insidious process of clinical signs. The two most common categories of clinical signs are metabolic and dermatologic. We see clinical signs in those categories, and about 70% of dogs have both of those categories. We can also see neurologic or neuromuscular clinical signs that can affect the heart and vasculature, and we can see reproductive clinical signs as well. In terms of the metabolic signs, so as I said, this is super common. It occurs due to decreased cellular metabolism or a generalized decreased metabolic rate. About 80% of dogs will have at least one of these metabolic clinical signs, and those include lethargy, weight gain, heat-seeking, exercise intolerance, and mental dullness. We also very commonly see dermatologic signs. Thyroid hormones play a very important role for the maintenance of hair growth and general health of the skin. So we certainly see a lot of different skin problems in dogs with hypothyroidism. One of the most common or classic findings would be what we call endocrine alopecia, which is when they have bilateral symmetrical alopecia or hair loss, typically on their sides or their back. It's typically non-pruritic, meaning they're not itchy. And then they also can get hair loss on their tail, which we've dubbed rat tail. They can get chronic ear infections, hyperpigmentation, scaling, secondary skin infections, and also a certain process called myxedema. That is when the skin gets an accumulation of glycosaminoglycans, and it causes the skin to be very thickened and puffy. It has a very classic look, which I have a photo of on the next slide. Just touching on some other clinical signs or associations that we have with hypothyroidism. So low thyroid levels can affect peripheral nerves. So we can see dogs with peripheral neuropathies where they might have weakness or changes with their gait, maybe subtle dragging of their legs or some knuckling. It has been potentially associated with laryngeal paralysis, which is sort of weakness or lack of movement of the voice box for when the dogs are breathing, and that can certainly lead to a crisis. It has been also associated with vestibular disease. So that is a problem with the balance center, a neurologic problem with the balance center. We can see reproductive failures. They can have trouble getting pregnant. They can have changes with their estrus cycle. It can affect, fertility and their ability to carry to term. And it also can affect the heart. It can slow the heart rate, lead to arrhythmias. And then there is sort of one of the more severe, though it is rare, but life-threatening presentations of hypothyroidism is called a myxedema coma. So that is when dogs will present, essentially they can be comatose. They have a low heart rate, a low blood pressure, low body temperature, and they require really aggressive thyroid supplementation and supportive care. Even with that, sometimes they don't make it through hospitalization. This is a photo of a dog in a myxedema coma, and you can see it has those skin changes, the myxedema skin changes, where the face is puffy, we have thickened skin. It has been called tragic face before, if you've heard that before. So this is a very rare complication, but we can see it time to time. And then I do want to mention that hypothyroidism has been associated with the formation of gallbladder mucoceles, which is when the gallbladder gets sort of clogged up with mucus and bile, and it can obstruct bile flow and can potentially be a surgical emergency. So that is one other association we have with hypothyroidism. So, what changes might we see on routine blood work that could be suggestive of hypothyroidism? If we look on a CBC or a complete blood count, we might see a mild non-regenerative anemia in about 50% of patients. It's typically mild, and dogs do not have any clinical signs from it. On a chemistry panel, the most common sign that we will see will be an elevated cholesterol in about 75% of dogs. Very important that we're testing on fasted blood because recent meals eating can certainly elevate cholesterol, and we want to make sure that it's a fasted elevation in cholesterol. We can see liver enzymes elevated, ALP, GGT. About 30% of dogs have that, and that's suspected to be from some fat deposition in the liver. And then about 35% of dogs might have mild elevations in their creatine kinase, which is a muscle enzyme. So now diving into our options for directly testing thyroid function. There are many different ways to assess our thyroid. Unfortunately, there's no single perfect test for it. We have our total T4, free T4, endogenous TSH, thyroglobulin antibodies, T3 testing, though that generally is not very accurate, certain stimulation tests, thyroid scintigraphy. For the purposes of this lecture, I'm going to focus on the ones we use most commonly, which are total T4, free T4, and endogenous TSH. So testing a total T4 is a common first-line diagnostic. Most primary vets will routinely test a total T4 yearly once dogs start to hit middle age. It is a good screening test because it is highly sensitive, meaning a dog with a normal T4 is very unlikely to have hypothyroidism. However, it is not very specific, and that means that a low total T4 unfortunately does not confirm hypothyroidism, and that is because there are many factors that can affect a total T4. Starting with breed, we can see Sighthounds, Basenjis, Doge de Bordeaux, all of them can have lower total T4s. Sometimes even it can affect their free T4s or T3s. Age, so as dogs age, their total T4 will decline. And non-thyroidal illness, so that's a really big one. Basically, this means that we can see changes with thyroid function secondary to acute or chronic illness, leading to decreases in total T4. And this is why we can really often overdiagnose hypothyroidism, because if we are taking a dog that has other illness going on, whether they have gastroenteritis or pancreatitis, if they're feeling sick from something else, oftentimes that total T4 might be in the toilet. And so it's not ideal to test for hypothyroidism when dogs are otherwise feeling sick from other diseases. And then drugs are another category. Steroids, anti-seizure medications like phenobarbital, certain antibiotics, certain non-steroidals, all of those can affect our thyroid testing. So we have to really take all of these factors into account when we're testing for hypothyroidism and interpreting the results. So for example, if I test a dog and I suspect they have hypothyroidism, they have the clinical signs to fit it, and I get a total T4 of 0.9, unfortunately, my diagnosis is not quite made yet, and I need to expand my testing. So that is where our free T4 and our endogenous TSH will come in. So testing a free T4, if you remember, that is the biologically active form of T4 that is free and not protein bound has a very high specificity for hypothyroidism because it tends to be less affected by these extrathyroidal factors that we just spoke about. It's not 100% immune to them. Sometimes with really severe non-thyroidal illness or certain drugs, we can see that affect the T4, but it's much less so than the total T4. I also will often check an endogenous TSH. So if we're remembering back to our thyroid regulation axis, when TSH is released by our pituitary gland, and thyroid hormone is responsible for turning off that release. So it should exert negative feedback. So if we don't have thyroid hormone in the body because a dog is hypothyroid, TSH is being released without any negative feedback, basically no off button. And so a dog that's hypothyroid should have elevated TSH levels. Unfortunately, it is not the most sensitive test because about 25 to 38% of dogs that are hypothyroid will have a normal TSH. So no one single test is perfect. We have to often use these tests together to try to reach our diagnosis. So in our example where we had the total T4 of 0.9, I added on a free T4 and this endogenous TSH. My free T4 was low at 0.3. My endogenous TSH was high at 1.27. So this is a nice example of everything fitting together to reach that more definitive diagnosis and confirm hypothyroidism in a dog that also has those clinical signs. So how do we treat hypothyroidism? Luckily, it's pretty straightforward and not, and pretty easy and well tolerated. It involves basically hormone replacement for the rest of the dog's life. We give synthetic thyroid hormone that can come as thyrotab, siloxane, levothyroxine. Those are all different names for it. I typically start at around 0.02 milligram per kilogram twice daily on an empty stomach. Some people will start once daily. Sometimes people, once a dog is well controlled, will drop down to once daily. There's a little bit of just different preferences by different vets. It is generally pretty well tolerated. Sometimes we can see gastrointestinal upset, and very rarely we can see skin hypersensitivities, but that's very uncommon. In terms of monitoring, I typically will check a total T4 about 1 month after starting treatment. And the timing of this blood work is really important because we want to check our T4 at sort of peak blood levels, and that occurs 4 to 6 hours after giving the medication. So we want to schedule that appointment for 4 to 6 hours after their morning dose of their thyroid medication. And I generally aim for a total T4 that's going to be in the high end of the normal range. In terms of clinical signs, they can all have sort of their different timeline for recovery and improvement. Generally, though, in a few days to weeks after starting treatment, we might see improvement in dullness, improvement with our lethargy, and increased activity. In about 2 to 3 months, we might see improvement with our weight loss, improvement in dermatologic signs, and it can take up to 6 months to see neurologic improvement. That takes the longest. So briefly touching on hypothyroidism in cats. The most common cause of hypothyroidism in cats is what we will call iatrogenic, and it's secondary to treatment for hyperthyroidism, so overdoing our treatment for hyperthyroidism. However, it can occur naturally, though it's pretty uncommon. When it does occur naturally, the most common cause is congenital hypothyroidism, meaning that these cats are born with a defect in their thyroid hormone production, as opposed to acquiring it as an adult. So that's the opposite for dogs. Dogs more likely acquire it as an adult. And in cats that have congenital hypothyroidism, it can affect their growth. So they have stunted growth and get this disproportionate dwarfism where their head is very big and wide. They have short little legs. They are very cute, but unfortunately for them, their skeleton has just not matured the way it should. They often also can have mental dullness, and we often see them for constipation. You can see an X-ray here where this poor kitten's belly is just filled with poop here. And we can also often see on these X-rays that their vertebrae have not formed correctly. Diagnosis is similar as with dogs. We look at a thyroid panel looking for a low total T4, low free T4, and an elevated TSH, which will be a pretty reliable finding and pretty sensitive finding in these cats, regardless of the underlying cause. Treatment is similar as with dogs. We give them thyroid supplementation, but unfortunately, the prognosis can be variable. It really depends, especially for these congenital hypothyroid cases, how quickly we are catching it and intervening, sort of where they are at with their skeletal metabolism, how bad the constipation is. So unfortunately, the prognosis in some cases is not always good. Okay, so that's hypothyroidism. Moving on to hyperthyroidism, this section will focus on cats mostly because that's where we mostly see the disease. And then in the end, I'll touch on hyperthyroidism in dogs. So hyperthyroidism is defined as a clinical condition that results from excessive production and secretion of thyroid hormone by the thyroid gland. It is the most common feline endocrine disorder, and we see it in about 10% of senior cats. I'd like to take a moment for us to understand how cats get hyperthyroidism and what sort of the disease pathogenesis looks like. So starting with a normal cat, a normal thyroid, there might be a few cells that start to grow a little bit more than normal. That is called thyroid hyperplasia. So these cells start to proliferate. They might start to cause or form little nodules. And then eventually over time, those nodules will coalesce into adenomas. So adenomas are technically tumors, but they are benign. They do not metastasize to other parts of the body. They are not locally invasive. They are benign tumors that will continue to grow in size, but don't tend to act aggressively. And this is the stage that we are often diagnosing our cats. When we diagnose them with hyperthyroidism, they, in the vast majority of cases, will have a thyroid adenoma, and that's the cause of it. In about 1 to 2% of cases, rarely, they might have a thyroid carcinoma, which is a malignant thyroid tumor that might grow bigger in size, will be locally invasive, might have start to spread sort of beyond the two thyroid lobes and cause nodules elsewhere in the neck. And there are two different ways that they can get the thyroid carcinoma. One is that it's thought that these adenomas might transform into thyroid carcinomas over time, or it's possible that it started as a carcinoma from the beginning. But like I said, the vast majority of our cases when we are diagnosing hyperthyroidism are at this stage right here with a benign thyroid adenoma. And it can be on one or both of the thyroid glands. So this is a disease of older cats. The majority are over 8 years old. There is no sex predisposition, and interestingly, purebred cats, particularly Siamese and Himalayans, might have a decreased risk of developing hyperthyroidism. What are the clinical signs that we see? So weight loss with a ravenous appetite is one of these classic findings and often one of the main presenting clinical complaints from owners. We might see hyperactivity, increased vocalization in the home, increased thirst and urination. Unfortunately, these cats don't often keep up with their grooming habits and they often have a pretty unkempt hair coat. We might see behavioral changes, and that can range from changes with their sleeping habits to new aggression, where it was previously a very sweet cat, and all of a sudden they're being aggressive either with the vet or even with the owner. And we also can see vomiting and diarrhea. The vomiting these can be just from the thyroid hormone, excess thyroid hormone directly, but also a lot of the time these cats are vomiting because they are scarfing down their food and eating so ravenously that they're just overeating and then vomiting from that. And then a very small subset of cats, less than 10%, will present with what we call apathetic hyperthyroidism. So that is when cats present with lethargy and a decreased appetite instead of that typical ravenous appetite with hyperactivity. In terms of the physical exam, one of the first things we'll notice is weight loss, thin body condition, muscle wasting. Sometimes the muscle wasting even precedes our fat loss. So a cat might still have some fat on them, but on our exam, we'll notice decreased musculature. Like I said, they can have an unkept. And we always feel, on every cat for a thyroid nodule, but particularly for our cats where we suspect hyperthyroidism, we will sort of lift up their head and we gently palpate down their trachea to try to feel what we call a thyroid slip. And so we're feeling for that adenoma on either or both of the thyroid glands and seeing if we can palpate that we go all the way from the right under the jaw down to the thoracic inlet. And then, of course, we listen to their heart. They might have a heart murmur. They might have a gallop sound because thyroid hormone can affect the heart, which we'll talk about. So one of the important clinical consequences of hyperthyroidism is the development of hypertension or high blood pressure. About 30% of cats will have high blood pressure at the time of diagnosis, but it's very important to make sure that this is a real finding. These cats can be very stressed in the hospital or at the vet, and they could have what we call the white coat effect, where they are just stressed and it's transient hypertension that resolves at home. So we want to make sure that we feel confident in the diagnosis. And then the other thing to consider, if we do really believe they have hypertension, is that the hyperthyroidism might not be the only contributing factor. Oftentimes in older cats, they can have other diseases like chronic kidney disease, which also causes high blood pressure. So it might not be the only thing contributing to high blood pressure. When we do our exam, we look for signs of high blood pressure. And so when we check a cat's vision, that is one of the things we're looking for because high blood pressure can sometimes lead to blindness because of damage to the retina. So here we have an example of hemorrhage and some detachment that was the cause, that was the result of high blood pressure. And when we're looking at the cat, we can see that the pupils are very dilated and don't seem really responsive to the light, which is a sort of first red flag that this cat might be blind. And we, of course, want to monitor our blood pressure as we treat the hyperthyroidism. There is a very small subset of cats that can start off with a normal blood pressure and then develop high blood pressure as we treat the hyperthyroidism. So I will monitor blood pressure not just at the start, but through our treatment and through follow-up. Another clinical consequence that I briefly talked about was cardiac abnormalities. So elevated thyroid hormone can lead to increases in heart rate, strength of contraction, arrhythmias, increased metabolic demands of all of the peripheral tissues. And all of that together can ultimately lead the heart to enlarge, and we can see dilation of the chambers, thickening or hypertrophy of the walls. In severe cases, that can lead to heart failure. But the good thing in these scenarios is that oftentimes these changes are reversible with the treatment of hyperthyroidism. Sometimes there are cases that have gone on too long, not treated, where those changes might not be reversible, but generally we can often expect to see the heart sort of return back to normal in appearance and function when we treat the hyperthyroidism. So what might we see on our general screening diagnostics that could be consistent with hyperthyroidism? On a CBC and chemistry, we might see an elevation in red blood cell count. That is from the stimulatory effects of thyroid hormone on the bone marrow. we very commonly will see mild elevations in liver enzymes, typically ALT and also ALP, though these are generally mild and they tend to improve as we start treating the hyperthyroidism. On a urinalysis, we might see a decrease in urine concentration and mild protein in the urine. And then, of course, we want to check our blood pressure. So what does thyroid function testing look like for cats? It's a lot of this similar tests that we talked about for hypothyroidism in dogs. We have our total T4, our free T4, endogenous TSH, nuclear scintigraphy. T3 again is not super accurate in cats, and T3 suppression test is an older test that we don't use as commonly. So we are going to focus on total T4, free T4, endogenous TSH, and nuclear scintigraphy. So we often start with checking a total T4. It's our first line screening test, and it is generally very highly sensitive for hyperthyroidism. It will be elevated in about 95% of hyperthyroid cats. So there are many scenarios where I have a cat that seems hyperthyroid based off of the clinical history, the physical exam. It has a thyroid nodule, and I do a total T4 and it's elevated. Let's say it's 7, and my diagnosis is essentially done. I have enough to say this cat has hyperthyroidism. However, it can be affected by non-thyroidal illness, certain drugs. So we always want to take into account what else could be going on with the cat at the time of the diagnosis when we're interpreting a total T4. And then a very small proportion of normal cats might also have an elevated total T4. So it is not perfectly specific to hyperthyroidism. So sometimes we find ourselves in a scenario where we have a total T4 that's normal or in a high normal range in a cat where I strongly suspect they have hyperthyroidism. And in that scenario, I generally take one of two approaches. I might consider retesting the total T4 in about a month or two, or we can expand our testing now to try to reach that definitive diagnosis. And that's where I will then go to checking a free T4 and a TSH. So our free T4 is even more sensitive than a total T4, with it being elevated in about 97% of cats that are hyperthyroid. They unfortunately can have false positives, though, especially when cats have non-thyroidal illness like gastrointestinal disease. If we're testing our TSH, so that is released by our pituitary gland, and thyroid hormone is normally responsible for inhibiting TSH release. So if we have high levels of thyroid hormone that are inhibiting TSH, then in a hyperthyroid cat, our TSH should be low. And it is a very sensitive test. It will be undetectably low in about 98% of hyperthyroid cats. The problem with it is that it is not specific. So normal cats might also have a low TSH. So we don't have one perfect test, but oftentimes by combining our total T4 with these additional tests, we're able to our diagnosis. Scintigraphy is a form of thyroid imaging in cats that can be very helpful. It is largely considered the most sensitive, most specific test for hyperthyroidism. It is performed by giving a radionuclide, and that radionuclide gets trapped and concentrated within the thyroid follicular cells. It does require special licensing and facilities. Unfortunately, we don't do it at AMC, but Dr. Peterson at the Animal Endocrine Clinic does it in New York City. And it has a whole host of different benefits. So it's highly sensitive and useful if blood work is equivocal. It helps to discriminate unilateral versus bilateral disease. It helps to identify ectopic thyroid tissue. So ectopic meaning that it is in an abnormal location. So if we look at this scintigraphy here, on the left we have normal. So those are our two thyroid glands. And then on the right, we see both of our thyroid glands, though asymmetrically, both have nodules. So abnormal in that sense. And then we also see this blip here, and that is ectopic thyroid tissue that is lighting up right under the jaw. So that is where scintigraphy is really useful to find where that abnormal tissue is. It might also identify some concern or features that could be consistent with a carcinoma if it's really large, if it's really locally invasive. Ultimately, a tissue biopsy is needed for that definitive diagnosis. Is used also for determining the treatment dose of I-131. So it's essential for that role as well. So moving on to our treatment options for hyperthyroidism, we have four options in general: antithyroid drugs, a low iodine diet, radioactive iodine, and surgery. Generally, we are aiming to lower our thyroid hormone and minimize the effects on the body of excess thyroid hormone. However, radioactive iodine and surgery are different than these first two because they also are what we would call curative or definitive treatments, meaning they are aimed towards destroying or removing that abnormal thyroid tissue that's causing the problem. So, just talking about our medical management a little bit more, we have our antithyroid drugs. So most commonly here in the US, we use methimazole. Carbimazole is also another version of that. They use that more commonly in Europe. And this medication works by blocking thyroid hormone synthesis because it inhibits a specific enzyme. So in this whole process of thyroid hormone production, it inhibits thyroid peroxidase right here. So it blocks that production, but doesn't do anything to kill this actual cell that might be, that is sort of proliferating abnormally. I typically will start at around 2.5 milligrams twice daily. It does come as a pill or transdermal option. Transdermal can be very useful if your cat does not take pills very easily, though it does sometimes require higher doses and sometimes can be a little bit, take a little bit longer to take effect. Generally, it takes about 2 to 4 weeks to see the effect on the T4, so maybe a little bit closer to 4 weeks for the transdermal options. And long-term control can be achieved in about 75–85% of cases. That number is a bit higher in the beginning because, and then it sort of lowers with time, most of the time because we're having progression of that thyroid nodule. It might require higher and higher doses of methimazole over the course of years because we're not doing anything to stop the growth of that adenoma. So methimazole does come with various potential side effects. Most of the adverse reactions will occur in the first 3 months of therapy. Most commonly, we can see vomiting, diarrhea, anorexia in up to 25% of cats. Normally, those can be managed with supportive care. They don't typically require us to stop the drug, but in really severe cases, sometimes I will switch out to the transdermal option because that is better tolerated from a GI perspective. We can see uncommonly, but it's quite distinct when it happens, facial excoriation. So cats will start really pawing at and scratching their face, the base of their ears, their neck. This is something that unfortunately we often have to stop methimazole altogether and consider another treatment option. Very rarely we can see blood dyscrasia, so disorders with blood where we have low white blood cell count, low platelet count, low red blood cell count. Liver toxicity is also a very serious one that is also rare that can occur. Myasthenia gravis, where that is a neuromuscular disorder, is also very rare but has been reported. So these are all things that we're going to be monitoring for when we start methimazole. And then one thing that we will see, regardless of our treatment, how we're treating the hyperthyroidism, is we might see an elevation in our kidney values once we start to treat hyperthyroidism. So I want to talk about that a little bit more because it's a really important concept. The kidney function is really influenced by thyroid status. So in a hyperthyroid animal, we see increased cardiac output and increased glomerular filtration rate, so increased blood flow to the kidney. And this leads to decreased kidney values. This is really an overestimation of kidney function. So it is making the functioning better than what their true ability is. So once we start treating the hyperthyroidism and we have normalization of the cardiac output, normalization of the blood flow to the kidneys, we will often see the kidney values start to worsen. And that is not that we are causing damage to the kidneys, but more so unmasking what their true level of function is. So it is a myth to say that, or not the correct, course to take to say we shouldn't treat hyperthyroidism because we don't want to worsen the kidney values, because we're really just unmasking what the real kidney function is. And long term, if untreated, hyperthyroidism isn't good for the kidneys. It can worsen chronic kidney disease over time. So it's not a reason not to treat hyperthyroidism. We do, of course, monitor our kidney values very closely. And as chronic kidney disease reveals itself, we will treat that, but not a reason not to treat hyperthyroidism. So back to methimazole, we will monitor it by checking a CBC, a chemistry panel, and a total T4 in about 2 to 4 weeks after starting treatment. My goal is generally the low end of the normal range for my T4. If a cat has really severe kidney disease, I aim a little bit higher just so that we're not risking decreasing blood flow to the kidneys. And then the timing, unlike our dogs on thyroid tabs, timing of the blood draw is not important in relation to the morning dose of the pill. And as I mentioned, because that adenoma might still be growing over time, we might need to increase our dose of methimazole over time. Another option is the low iodine diet. So if you remember, iodine is required for thyroid hormone synthesis. And the idea is that chronic restriction of iodine in the diet will decrease thyroid hormone production over time. When it's successful, it has a very high response rate of 82%, but there are a few caveats. The cat has to strictly adhere to the diet. They can't have other treats. We have to be really cautious with what they're eating. And unfortunately, it's not the most palatable of diets. The other problem is that if these are older cats where they might have IBD, they might have chronic kidney disease and might require specific diets for those diseases. So oftentimes we don't want to be mixing diets and we have to prioritize the other diet over this. And then it might be less effective in really severe cases where we're starting with a thyroid level that's really high. It generally does also have a slower time to effect, so about 6 to 8 weeks. Moving on to radioactive iodine as a treatment option. So this is similar principles to what we discussed with the nuclear scintigraphy, where we take radioactive iodine, which is a radioactive form of stable iodine, and it is injected in the cat and it then concentrates in the hyperplastic or the cancerous thyroid cells, irradiating that hyperfunctional tissue. It is locally destructive, but is able to spare the normal tissue around it, which is really the beauty of the treatment. Our goal is to restore normal thyroid levels and avoid hypothyroidism. And as I mentioned before, this is a curative, irreversible treatment. So we are aiming to really destroy those abnormal thyroid cells. Typically, a one-time injection under the skin is sufficient. No anesthesia is required, but one of the downsides is that the patient has to be hospitalized for typically at least a few days because of the radioactive nature. And it might even be longer. There are different state regulations depending on what state you're in. In terms of monitoring, it can take 3 to 6 months for the atrophied normal thyroid cells to then regain their function. We typically will recheck a T4, TSH at 1, 3, 6, and 12 months post-treatment, and then yearly. I say we at AMC, we don't perform this, but again, Dr. Peterson at Animal Endocrine Clinic does perform it, as well as other facilities. And we do want to monitor their kidney values closely, and especially if they are hypothyroid afterwards, they might be at risk for having higher kidney values. So we pay close attention to that. It has an excellent prognosis, with about 95% of cats being cured from hyperthyroidism after a single injection. But it is important to note that about 15% of those cats might be subclinically hypothyroid, so they might just have an elevated TSH or a little bit of a low T4. Those cats will be closely monitored, and oftentimes that will normalize. About 5% of cats might be overtly hypothyroid and over time might have clinical signs of hypothyroidism, elevated kidney values, and sometimes those cats will need supplementation. About 5% of cats will remain hyperthyroid, requiring a second treatment, and they often, it's pretty successful after the second treatment. This is a fairly recent study from Dr. Peterson where they looked at predicting outcomes in hyperthyroid cats treated with radioiodine, and they found that those that remained hyperthyroid were more likely to be younger, more severely affected, having lower I-131 uptake. And then this wasn't in the study, but we do know that thyroid carcinomas tend to be more resistant and require higher doses of treatment. So that would also be potentially a reason for them remaining hyperthyroid afterwards. And then our last treatment option is surgical removal or thyroidectomy. It's generally an effective treatment. The definitive treatment option, or the goal is for it to be definitive by removing that underlying abnormal tissue. Success rates of over 90% most of the time. It is ideal to perform scintigraphy prior so that we can know whether the disease is unilateral, bilateral, if there's any ectopic tissue that needs to be approached with a different surgical approach, because if it's in the chest or under the jaw, they need to know where to look. Some disadvantages are that it does require general anesthesia, and sometimes these are older cats that have other comorbid heart disease, kidney disease, so you need to take that into account. There is risk for hypoparathyroidism, which essentially parathyroids regulate calcium, and they live sort of in and within the thyroid gland. So if those are removed entirely, cats can become have a low calcium, and that can be a real crisis. And then they can also have hypothyroidism after removal. And then very rarely we can see recurrent hyperthyroidism due to tissue regrowth or potentially not removing all of the abnormal tissue at the start. I will say this is not super commonly pursued because we have I-131 available, and it's a less invasive and really effective option, but sometimes there's the right case for surgery. So those are our main treatment options, and really, how do we decide what is right for you and your cat? And there are a lot of things that we have to take into account. It's not one size fits all. We will take into account the age of the cat, of course. If it's an 18-year-old cat that has chronic kidney disease, we probably are not going to put them through surgery. We probably, might not consider I-131 because they could do well for a few years with methimazole. Considering the severity of hyperthyroid clinical signs, the size of the tumor, how concerned for a carcinoma are we? If so, maybe we're looking at more definitive treatment options. Owner's ability to give medications and the cat's tolerance of the medications. It's oftentimes easier said than done. And as you know, we can sometimes see effects of methimazole. So sometimes that is taken out of the equation and we have to figure something else out. And then, of course, costs and availability of treatment options. We're lucky here in New York City to have all of these treatment options available to us, and then risks of treatment complications. Hyperthyroidism in dogs. So this is most commonly caused by a functional malignant thyroid tumor. Less commonly, we can see it from oversupplementation when treating hypothyroidism. And then we can also see it if they ingest raw or dried uncooked diets that contain thyroid tissue. When they have a thyroid mass, they often present due to the thyroid mass being large and palpable. They might have signs associated with the thyroid mass, like changes in their voice or their bark or trouble swallowing. And then they might have signs of hyperthyroidism, like increased thirst, urination, increased appetite. In terms of the diagnosis, we typically will do a full thyroid panel looking for our elevated T4, free T4, low TSH. we then do imaging of the mass. So that might include an ultrasound, a CT scan here. We can see the thyroid mass. Scintigraphy can be used. And then, not super commonly, but we can aspirate the mass to try to get a cytologic diagnosis to confirm that they're thyroid cells. But thyroid masses often have a pretty big vascular supply and they can be very bloody when we aspirate them. So there's risk of bleeding, and also sometimes it's not diagnostic because we just see blood. And then treatment options really depend on the individual case, how big the mass is, how fixed to the neck it is, the dog's age, and other comorbidities. In an ideal world, we like to surgically remove them, but that's not always possible. So we sometimes consider radiation, radionuclide therapy, which requires pretty high doses of the radioactive iodine, chemotherapy, and then to control clinical signs, methimazole is sometimes used or to sort of stabilize them preoperatively. Okay, so then our take-home slide. So for hypothyroidism, it is a common disease of middle age to older dogs. It is very easy to overdiagnose, so we want to be cautious of that. Low thyroid can affect multiple body systems, including skin, nervous system, metabolism. Treatment involves lifelong thyroid hormone supplementation, and dogs can have an excellent long-term prognosis. Congenital hypothyroidism in cats is rare and can affect their growth, mentation, and lead to constipation. And then in cats with hyperthyroidism, it is the most common endocrine disease of older cats. We will often see it present with weight loss and a ravenous appetite. They might be hyperactive, have increased thirst and urination. Treatment options include diet, methimazole, radioiodine, and surgery. And treatment decisions really have to be tailored to each individual case and making an informed decision with your vet about your own cat. Cats can have a good long-term prognosis with it. And then hyperthyroidism in dogs is most commonly associated with thyroid cancer. And that is everything. I know it's a lot of information. Thank you, everyone. And if we have any questions.
Well, thank you so much. I know it was a lot for you to present, and you did a fabulous job. And thank you for sharing your expertise with everyone. We do have some questions, so we'll get to as many as we can. Just why bother with total T4 if you rely upon free T4 to cinch whether or not dogs need supplementation
Yeah, so
regarding, yeah,
Yeah,
hyperthyroid.
it's a good question. Free T4 can be more expensive, and also requires a certain type of testing by equilibrium dialysis to be most accurate. So generally, we'll start with the total T4, and then if we need to do that more advanced testing, go to the free T4.
Okay, okay, great. Are thyroid tests similar to ones done for humans? If you're aware. Yeah,
Yeah, these
yeah,
these are
yeah.
I don't know extensively what
Yep.
the human testing. I know, with hypothyroidism, I believe in humans, the TS, they'll often just test for a TSH, and that is their test of choice, I believe. So I think, they have all of the same individual components. I don't know if they rely on our like total T4 and free T4 as much, but it's a lot of the same individual tests.
Okay, great. What cat foods are low in iodine beyond prescription food? Is
Yeah.
human protein with fat like chicken skin okay?
So I have tried to work with a nutritionist
Mm,
in a cat where they didn't like, there's really just the Hills YD. That is the ideal option. I reached out to a nutritionist because I had a cat that wouldn't eat it. And what they said was that they can try to make a low iodine diet, but oftentimes it's just not low enough and they're not able to really have sustained success with it.
okay, okay, great. For dogs with hypothyroidism, how does primary thyroid dependent versus secondary pituitary dependent impact the rate of disease progression? Should the treatment strategy depend on primary versus secondary?
Okay, so secondary also is pretty uncommon. That would mean that there is a problem with the pituitary gland, and that can come from different things. It could be from potentially a tumor of the pituitary gland. So if if we suspect a dog has secondary hypothyroidism, we'll likely recommend imaging of the head, so an MRI, and then treatment of that would depend on what the underlying cause is, in addition to thyroid hormone supplementation. So we need to supplement thyroid hormones similarly. However, if we find something like a tumor, then that would be treated sort of as tumors are treated, depending on, where you are, the extent of it, and all of that.
Okay, great. We had a few questions asking about aggression in dogs with hypothyroidism. Do you, let's see, how
Sorry, can
often
you
do,
repeat that? You just
okay, am I freezing too? How
Yeah.
often do you see aggression in dogs being caused or related to hypothyroidism? In the dog world, we have some who feel that hypothyroidism, there are a
Yeah.
couple questions about that. Is a
Yeah,
causal?
it is certainly something that we can see, aggression, behavior changes. I would say I don't think that I personally see it that much, but I wouldn't be surprised if somebody is reporting it.
Okay. We had a question. I would love to hear more about the relationship between hydrocephalus and thyroid disease. I think you're freezing a little
Okay.
bit. Okay, okay. Here you go. Um,
So sorry, you're freezing a little bit. I don't know if
we're
it's
both
me or
freeze.
you,
I don't
but
know.
can you
I don't
hear
know.
me?
I can hear you now. Yeah, we're having a little
Okay.
freeze. So,
So that is an interesting question. It is not a typical finding of to see hydrocephalus and hypothyroidism together, or congenital hypothyroidism. We do know that thyroid hormone is really essential for neural development and the development of the brain. So a way to potentially connect the two would be if a dog, for whatever reason, is congenitally hypothyroid. As its brain is developing, it's not getting enough thyroid hormone, and it leads to that hydrocephalus. Hydrocephalus is basically swelling of the compartments of the brain with cerebrospinal fluid. So that's one way. The low thyroid potentially can impact brain development, leading to the hydrocephalus. If we were to think about it as, can the hydrocephalus cause congenital hypothyroidism? I don't know what the entirely correct answer is. I would suspect that there could be a way where they might be related, because hydrocephalus can increase pressure in the brain, and then it might cause increased pressure on the hypothalamus and the pituitary gland and disrupt that axis that is leading to, stimulating the thyroid to make thyroid hormone. So that would be the connection, I would suspect.
okay, okay.
Yeah.
All right. What is the aftercare for a cat that has had the radioactive iodide treatment?
Yeah. So I'm not the expert in the aftercare because I don't perform it,
Okay.
but they need to be somewhat isolated, I believe, for at least a few weeks afterwards. And but otherwise it is not invasive. So they don't have any incisions that need to heal. It is just an injection under the skin. So there's not too much aftercare in terms of taking care of them. They should feel well. It's just a little bit of precautions because of the radioactive nature.
And
Yeah.
okay. Let's see. Now we have some questions about the medication. A similar question, actually. What precautions does the owner need to take with the administration of the
Yeah.
drug and handling the cat?
Yeah, so I didn't mention that, but you should wear gloves when handling
Okay.
it, especially for the transdermal option. It can potentially be absorbed through the skin, so I always recommend that owners wear gloves when handling it.
Okay, great.
And we want to avoid also like splitting the tablets.
Oh, that's good to know.
Mhm.
Okay. Okay. Yeah, that was another question. So, let's see. How many years can a cat be on that medication?
So indefinitely, there is not a hard and fast rule in terms of how long they have to be on it. As long as it is controlling their hyperthyroidism, they can be on it forever. The question becomes, if their thyroid adenoma is growing in size and the thyroid levels are becoming more and more resistant to that dose of methimazole, they might need increasing doses. So dose might need to increase, and sometimes you might reach a point where we're reaching really high doses and might consider other kinds of treatment options. And of course, you can't be on it if you're having some of those severe side effects, but cats can potentially live the rest of their lives on it.
Okay. Okay, great. And is there a maximum dose that they can be on
So
or?
they're around around 10 milligrams with the dose, but it's not a rule that they can't go over it. So that is generally where I will tend to say, okay, what's going on here? Do we need to consider, scintigraphy, looking for, is there, a significant ectopic tissue? Do we think this is a carcinoma? So around 10 milligrams is where I think of it, but it's not a hard and fast rule.
Okay. Should breeding dogs be tested if a hypo dog is in their line?
So it's an interesting question. So there are some genes that we suspect could be related in certain breeds. I don't know how widely available testing is for that. However, there is one of the tests that I didn't really go into detail about is the thyroglobulin autoantibodies, which basically could be an indication of having antibodies to the thyroglobulin and a sort of a precursor or cause for lymphocytic thyroiditis because they have those autoantibodies. So that, and I believe, might be used in some breeding capacities as a sign of this dog it can be an early marker of lymphocytic thyroiditis. So that could be potentially used as an indication, maybe not to breed that dog.
Okay. Okay. Would a radioactive iodide treatment be acceptable for use in a cat with chronic kidney disease?
So there's not a yes or a no, and that is part of the workup in question. It depends how severe the chronic kidney disease is, and oftentimes we will, or the person performing radioactive iodine will do a methimazole trial first. So a cat might have technically normal kidney values while they're hyperthyroid, and then as we treat the hyperthyroidism, we reveal that they have chronic kidney disease. So we sometimes will do a trial with methimazole to see what their kidney values do. And the benefit is that it's reversible and it's not definitive like I-131. So if we put the cat on methimazole and the kidney values when they are when they have a normal thyroid level jump up to 3 or 4, and we know that the cat has really significant chronic kidney disease, might not be a good candidate for I-131. But there isn't necessarily a specific kidney value that's the cutoff where we say they can't get it or not generally. We tend to do that trial.
Okay, great. All right, we'll take a couple more. Okay, this one's a little complicated, but I'd love to learn more about interpreting thyroid panels, particularly the role of T3. How should we think about T3 in relation to T4, especially when results don't align? For example, what is the significance of a low T3 with a normal or elevated T4? And how much weight should T3 carry in treatment?
I don't put I very rarely test it.
Okay.
Honestly, I don't put much weight into it. It can lack sensitivity and specificity. So I generally don't do a lot of T3 testing.
Okay. Yeah, we have some question about not splitting the pills. So that's, yeah. Let's see. Or crush them, right? Both of them, yeah. Let's see. Um, let's see. Is it possible to mitigate an elevated T3 autoantibody in a young dog with otherwise normal range thyroid values?
Unfortunately, there's probably not much to do. You could potentially say, oh, if we immunosuppress the dog, can we prevent that? But then you're dealing with side effects of steroids and immunosuppression. And I generally wouldn't, which honestly might be worse than just giving the dog thyroid hormone. So I generally wouldn't intervene. I would just monitor.
Okay. Let's see. How common is vestibular ataxia due to hyperthyroidism? And if an older dog is diagnosed with vestibular disease, should it be tested for low thyroid?
Yeah, I would say that, and that might be a question for the neurologists, but
Hmm.
it is an association. We don't have the strongest evidence for causation, but it is something that we do think we see not very commonly. I do suspect that it is part of the workup when our neurology team gets a dog that has especially central vestibular disease. They'll often check a thyroid level.
Okay, great. And many people saying thank you so much for this. And someone else saying, is there a way we can watch it again? Yes, it will be on our YouTube channel, and we'll send out that link tomorrow afternoon. And with that, we're already over quite a bit. So thank you again, Dr. Covo. Thank you again for Dr. Covo for your time and insight. It was really just a wonderful presentation. I know a lot of it's a very complex topic, a lot to get to take in and a lot to put out there, but I think you did a really fantastic job. So thank you for that. And thank you to everyone who attended tonight and asked such thoughtful questions. Just a reminder again that it was recorded. We'll be sending out the link tomorrow. And we hope you will join us for our next webinar, Dental Health in Dogs and Cats, on Thursday, February 26th at 6 p.m. On behalf of AMC and my colleague Valeria Menendez. We want to thank you for spending part of your evening with us. And please, everyone, stay safe and warm during this extreme cold. But again, thank you again for supporting our programming and for being with us tonight. Okay, everyone, have a great night. Thank you.
You.
Bye.